Thanks for having me. So yeah, my name's Chris Bates. I am Director of Research and Analytics at TPP. TPP, we're an electronic health records provider, clinical information systems provider. So we supply systems for general practice and hospitals and mental health settings, for example. And we supply that to about 50 million. We have records for about 50 million people across all those settings in the UK. So we've always run a big central database, on behalf of NHS colleagues that hold these electronic health records for people. And as Jess has said, about a year ago now, we had the first conversations with Ben Goldacre about some other research as it happened, but we turned quickly onto this. And we were able to work very collaboratively together with small teams on behalf of NHSE to build this platform. And what that means is that we have this big research database which sits inside the central infrastructure we have inside secure NHS accredited data centres, and then Ben and the team and the epidemiologists at other research institutions can effectively dial in the secure way that Jess has pointed to, and there's lots more information on the website, to be able to run those analyses, retaining the power of being able to work on really big data and really high dimensional rich data, but without compromising confidentiality in probably the most tightly regulated data sets imaginable. What I want to do today is to show you what the sort of consequences of the model we've built and the data sets that we've built are for rapid analysis for COVID-19. And as Paul said, I'm going to talk about vaccinations. Vaccination flow is kind of complex and kind of been a work in progress around the NHS. For any of you that are involved, I'm sure you know this, but ultimately, wherever a COVID vaccination is recorded, whether that's at Ellen Road, whether that's in a hospital, at your GP practice down the road, in a care home, it makes its way back onto your GP record. And that's the context of what we're talking about, because once that vaccination's on your GP record, it means it flows into the Open Safely database so we can start to do some interesting analysis. I'm just going to share my screen with you. Can people see that? Wave if you can.
Yes.
Great. Fantastic. So this is some analysis that came out very quickly. And this, the vaccination program starts kind of mid-December, and the vaccination flows start around that time into general practice. And then by early January, what we've got is we've started to get good information in the system to be able to do, some really interesting analyses. And what I want to talk about really is how those analyses in the context of the rest of the medical record have been able to mean we can do some more interesting things, and to really be able to track what's going on, to try and influence policy, and to really shine a light on what's happening. So this was picked up by The Guardian very early on, and you can see the discrepancies in the cohort there in terms of ethnicity. So this was looking at all the over 80 plus age group, the first cohort who were getting vaccinated, breaking it down by white, British, South Asian and black. And so you can see there we've got more than 80% of the white population had been immunised by the 27th of January, and you can almost halve that. And we could only do that because we've got that information in the system, but we've also got ethnicity data as recorded by the GPs. What is kind of cool about this, from our point of view, and from the audience today, is this is a link in The Guardian, and normally you might see a hyperlink there to a research paper, and it might be some a preprint or some published paper. But the link here is a link to the GitHub repo that Jess was talking about. So in that repository is all the analytic code that's gone behind this, the papers there, all the graphs, every bit of information you could want to be able to effectively see what we've been up to is available to people who technically want to get under the hood of what's going on with the data and want to analyse what code's been running. So it's as open as you can possibly be. I think that's great. If you follow that link, and you do that now, you'll start to see the sort of things we've been able to do. And to start with, these are kind of similar to things you could do from other data, just from the central data sources of who's been vaccinated. So we can see, this is last week's report or the week before, so you can see how many people have been vaccinated, how many in the 80 plus cohort, how many in the 70-90 cohort, and that's kind of stuff you can get from national statistics anyway. We start to be able to get a little bit cleverer in terms of how many people have been vaccinated within the care home population. It's actually a tricky question from address data to say who's living in a care home, and the people who've been involved in UPRN and geographic data sets on the joining us today will be well aware of that. And then we can sort of start to see more of a breakdown, who's had the AstraZeneca vaccine. So really just some simple descriptive statistics, which are very useful, but in the context of Open Safety, are not really utilising the whole power. Where we wanted to use the power was, as Jess alluded to, our first big publication, this was in Nature last July, was to look at the descriptive factors associated with COVID-19 death, because these have very much informed vaccination policy in the UK as to who we should be, this kind of work and lots of other work alongside it. So you can see here, as we all know, age is a huge factor. The red line there is a kind of hazard ratio of 1. Age, as you start to get older, becomes a really dominating factor for poor COVID outcomes. It was the same with ethnicity. If you come down there, the same with social deprivation. The more deprived you are, the more likely you were to have poor outcomes. And then into some, physical and mental health conditions. So at the bottom there, this isn't the whole list. We've got some cancer data showing that if you have, recently suffered with cancer, you are more at risk. Alongside that, as I've said, there's been lots of other work. The Joint Committee of Vaccinations and Immunisations, I'm sure most people are aware, have got lists of conditions of people now who we want to prioritise for vaccines, because lots of studies have been done, including that Open Safely work, who've really shone a light on who's most at risk. There's the JCVI list, but also other government things that we do know from publications from Public Health England and from UK Biobank, which some of you will be familiar with, in terms of pre-existing mental health conditions and the impact that has on poor outcomes for COVID, and people living with learning disabilities and the poor outcomes there. So all of this is fed into the cohorts we're trying to vaccinate as early as possible to give maximum protection we can in the country with the vaccinations we have. From an Open Safely perspective, we can then start to break down those cohorts. And again, this is all available on the GitHub repo. So if we're looking now at the 70 to 79 population, this is a population we're starting to finish, we can start to do those breakdowns. So on the left there is by ethnicity. It's kind of the graph I've already shown, but you can see, this is very, very recent. The Guardian article was January, and we haven't really changed that situation. We've still got that discrepancy there. It's multifaceted reasons for it, but it needs tackling. If you look to the right, that's about deprivation. And you can see that in this kind of univariable analysis, deprivation, it's still there. And we can see that trend. The least deprived people are more likely to be vaccinated, but it's not quite as stark as on the right. If we move to those clinical conditions, it's pretty good, actually. So, as I've said, cancer is a risk factor for poor outcomes. Recent cancer diagnosis is a risk factor for poor outcomes from COVID, but actually the yes and no's in that binary situation have both been vaccinated at a very similar rate and a very high rate. The same for dialysis patients. People living with kidney problems, again, were at risk. However, if we move to the other two I mentioned from PHE and from Biobank, if we look at intellectual disability and we look at psychosis, schizophrenia, and people living with bipolar conditions, you can see the discrepancy there. So we're able to use that data, this data set, to be able to say we do have to do some work nationally to close that gap between people living with intellectual disabilities and people living without them in terms of the vaccination rates. And how do we go about doing that? And I think that's really important for us. And what we're trying to achieve with Open Safely, and as Jess says, it's for the good of public health. We've been able to do this quickly and to highlight, from the data, real problems that need tackling now. We can't wait, 3, 4, 5 months before we get on top of these. So it's showcasing what's possible with good quality data. As Jess said, what we're really keen is that everyone can see exactly what we're doing. A lot of that analysis historically on healthcare data has taken place in the dark. So if you go to that repo, you can read how we construct study definitions and what the code looks like. And you can effectively read this in English. This is how we're defining who has had a COVID vaccination for the AstraZeneca vac for that cohort. And you can follow that code through, and that's exactly what it is, and that's what the analysis is running. At the same time, how have we defined how someone's living with psychosis, schizophrenia, or bipolar conditions? Again, in healthcare, and some of you won't be in healthcare, as much as possible, there are codes dropped onto patient records, so machine-readable codes, so that we can start to analyse those things with the machine, and we can actually do some analysis rather than just having text. But people in different areas often put different code lists together to mean, what do I mean by psychosis? Because these terminologies are very, very broad, and often that's not public. So again, Jess has posted a link to code lists. We've tried to make that really transparent so people can see exactly what we're doing and exactly how we're defining that condition. So upcoming results, what's next? I mean, if you ever want to see what's next, and I don't know if I can just switch screens, Jess alluded to the fact that we are trying to make this as transparent as possible. So this is live, this is real time at jobs.opensafely.org. And you can see at the bottom there under the latest jobs, there's a small blue circle twiddling away, and that's because what's running now, the job that's running, is about hospital disruption. So a piece of work, you can see exactly what analysis is running, and if you click on view and follow it through, you can see the GitHub repo, so you can see as transparently as possible the kind of work that the researchers are doing on this data set in real time to enable you to do that. So you can check that out and see what we're up to. In terms of vaccinations, what we're doing, well, the most interesting analysis that's about to come out is really around variants of concern. So we work very closely with Public Health England and NHS England to try and get the data as it's coming in, more data that we can link to this to enable the guys at Data Lab and at London School of Hygiene and Tropical Medicine to do this kind of work. So we've now got variant of concern data, so we're able to look at things like case fatality rate and transmission rates. And as new variants emerge, this is going to be a way of being able to do that rapid response. But rather than it being quite, a blunt way of doing that, as I say, we've got that rich EHR data. We can start to do breakdowns by different clinical conditions, different mental health conditions, and different demographic factors to try and get a better handle on what's going on and try and inform policy. As Jess said, everything's at opensafely.org, and the GitHub repos, most of them are public. They become public as soon as we can make them that way. If you want to ask Jess anything, it's at OpenSafely. And if you want to ask me anything, I'm Dr. Chris Bates on Twitter. And please, fire us with questions. I don't know if there are any questions.